Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
Hello everyone, so we're back at Be Kind Pediatrics here in the office today. The pollen count in New Jersey is about 800 billion, I'm pretty sure. So we are going to do a quick talk today about seasonal allergies. What are the mainstays of treatment? We'll talk a little bit about allergy shots, alternative therapies, and risks and benefits to all these therapies. So we hope you enjoy.
Dr. Rolnick, we've had a lot of patients come in with congestion, coughing. What do you recommend for those patients during this time?
So I think it's a great question in that coughing and runny nose has a pretty broad differential, so I'm glad you asked. And I think the first thing is you need to do a really good physical exam, because your question really is, what is the cause of the cough and congestion? And there could be a few causes, right? So cough and congestion can be an upper respiratory tract infection, which could be viral or bacterial. Cough and congestion and runny nose could also be any of those things, but add in some sneezing, watery eyes, itchiness, and potential eczema, and you're thinking something more like allergies. But really, this all starts with a really good physical exam, looking for signs of infection or seasonal allergies. That means taking a really good look at the nose, taking a good look at the skin. Kids with seasonal allergies tend to have something called allergic shiners, which are those dark purple circles under their eyes. They can get something called dandelions, which is a line, again, under their eyes. Their nasal turbinates tend to be pale and boggy as opposed to red and erythematous. Mm-hmm. They can also have something called the allergic salute, where kids, they kind of rub their nose upwards like this, and they get a crease in their nose here, so that's another sign of allergies. And then, of course, if they have any other, what we call like atopy, so asthma or eczema might flare up during seasonal allergy time if those are their potential triggers. So kind of looking at the big picture and deciding, what do you think this is the first thing. And then if I do decide that it's seasonal allergies mostly based on history and physical exam, then you're talking about what are the kind of three pillars of approaching allergy management. So the first one is avoidance. That works really well for things like food allergies and pet danders and things that are kind of in your environment that you could potentially avoid. Danders as well, you could potentially change the sheets, clean the pillowcases, get a humidifier. Pollen and grass are really hard to avoid because they're in your environment, which means you couldn't go outside. But there are things you can do to maybe mitigate your exposure. So if you have those types of allergies, sleeping with an air conditioner on, if you have forced hot air or forced air conditioning, potentially adding a filter to your forced hot air conditioning system. When you get home, changing your clothes, if you're covered in pollen, you might not be able to see it, but changing your clothes, taking a quick shower, getting it off your skin, those kinds of things can be helpful in avoidance. So after avoidance, the second line therapy, or I should say the first line medication therapy, so the second pillar is medications, and the first line is going to be, you have a choice between intranasal steroids and oral antihistamines. So let's talk a little bit first about oral antihistamines. You hear me talk a lot to patients about Benadryl, which is a first generation antihistamine, versus something like Claritins or Taxizol. Those are the brand names for the second generation antihistamines. So the first generation antihistamines don't really have a role in seasonal allergies. They're much more sedating. They have much more risk for side effects. And they are equally efficacious as the second generation antihistamines. So you get more side effects for the same amount of bang for your buck, basically. So oral antihistamines, second generation, you might want to start with those. And then if those don't work, I would say also first line and potentially even before the oral antihistamines are the intranasal steroids. And those have been shown to work just as well, if not better, than the oral antihistamines. They're very safe. They can be less well tolerated in younger children because they might burn a little bit when you spray them in your nose. They tend to have a kind of yucky taste, some of them. And so they just might not be as tolerated, and that might be a reason to go with the second generation oral antihistamine. Another reason to choose an oral antihistamine first might be like sometimes they see patients with seasonal allergic rhinitis, but they also have eczema. So obviously intranasal medication like a steroid isn't going to do anything for their eczema. So that might be another reason to choose oral antihistamine first. If you have eczema, you kind of get a little bit of treatment for both. And then really patient preference. So sometimes patients do really poorly on one first generation antihistamine and better on a second. And we don't know why that is, but switching between medications, even in the same class, can be helpful. So if you try Zyrtec and it's really not working, maybe switch to Xyzal and see if that works better. Know that the oral antihistamines take a few weeks to reach full effect, so you really need to give them some time to work before you make that switch. Same with the intranasal corticosteroids. And we know, interestingly, we do know that loratadine of all the second generation antihistamines is the least efficacious, so it's kind of the weakest one. So I would never choose that first if you're going for an oral antihistamine. There are now intranasal corticosteroids with intranasal antihistamines. It's a combination spray. It usually is not covered by insurance, so the cost is a potential side effect. But there have been studies that show that intranasal corticosteroids with intranasal antihistamines, the combination is superior to either one on its own. So either an intranasal antihistamine or intranasal steroid on its own, the combination is superior. So for me, usually the first thing I'm grabbing for a patient is a combination intranasal medication if the child will tolerate it. And besides the fact that they're slightly more efficacious, the intranasal antihistamine works much faster. So the onset is quicker than the steroid on its own, which can take several weeks. So at least the patient gets some relief sooner while I'm waiting for the intranasal steroid to work. If it's been a few weeks and that's still not cutting it, then you can potentially add on the oral medication. Or if you start with the oral medication, you can add on the intranasal medication. So that would kind of be the second step, a second generation oral antihistamine plus an intranasal medication. If both of those are failing, or the patient's not really getting any symptomatic relief after a few weeks and switching, make sure you switch between your oral antihistamines, switch between your intranasal steroids, and you've tried and those are still not working, you can add on a leukotriene receptor antagonist, something like montelukast. But the FDA just came out with a black box warning against montelukast that it increases the risk of suicidal ideations and or actions. And so they're really recommending its restricted use to allergic rhinitis, and they're really asking physicians to really reconsider using it in the context of asthma. So it's usually not a medication that I reach for even in the third line. Usually my third line is then referring that child to an allergist, immunologist for allergy testing and potentially allergy shots. So I should also mention that there was recently a study published looking at the duration of intranasal medications for seasonal allergic rhinitis. So the past thinking was that really this was a medication we started at the beginning of your seasonal allergies and kept patients on it for the duration of the allergy season. So if you're allergic to something like grasses, that's going to be spring, potentially all the way through winter. And so they did a really nice study looking at the duration of action, because if you pick up a bottle of Nasonex or any of the over-the-counter intranasal medications, it says used for 1 week and then PRN, meaning as needed. And that was really not what doctors were recommending. They were saying, just stay on this for 6 weeks. And this study basically looked at symptom duration, nasal flow, airflow through, which was measured obviously in the doctor's office. And was there any difference between 1 week and then as needed versus continuous therapy? And they found that in terms of lifestyle, so the symptoms that patients were reporting, there was no difference. There was a reduction in about 44% of the use, so 44% of the exposure to intranasal steroids, which are pretty safe, but they do have the risk of potentially thinning the skin of the nose, and they're irritating and cost, right? So in terms of symptoms, there was no difference. So it really begs the question about who should be on this for longer than 1 week. And I think that really depends on the patient population. If the nasal flow is really important to a patient, like very competitive athletes, for example, might notice a difference. Those might be patients that need to be on their intranasal medication for 4 to 6 weeks. But I think in everybody else, and most children 1 week and then as needed has the benefit of reducing their exposure to intranasal steroids as well as reduction in cost. So for most patients, I would say I'm going to tell them 1 week and then as needed.
Dr. Rolnick, if we have a patient that is on multiple allergy medications and their symptoms aren't improving, what do you recommend?
Yeah, so I think this is a lot of our patients right now, right? They're on second generation oral antihistamines, intranasal medications, and they potentially might even be on a medication for symptomatic relief of allergic conjunctivitis. And for the reasons I said before, I'm not really jumping from montelukast. And so once patients have been on this therapy, multiple medications for a few weeks, and it's still not working, or maybe we've tried this the season before and it didn't work, so this is the second season where we have them on 3 medications or more, 2 or more even, I think it is reasonable to refer those patients to allergists or allergist immunologists for potential subcutaneous immunotherapy or sublingual immunotherapy. And the reason is, I think it's very reasonable as a parent to try to, let's say you have a school-aged child and you're fighting them every day to get these nasal medications in and these oral medications in, and you're just had enough of having your child on multiple medications. I think that's a good time to talk to a specialist about it. And I certainly think it's reasonable to talk to one at that point. So usually once we have patients on multiple medications, or they're on multiple medications and they're just not achieving the lifestyle that they want, I will refer them over to an allergist immunologist to start discussing immunotherapy as a potential option.
Dr. Rolnick, can you explain what immunotherapy is?
That's also a great question. So I think the colloquial term for immunotherapy is allergy shots. But really there's allergy shots, and now there is sublingual immunotherapy, which is dissolvable tablets that you put under your tongue. The sublingual immunotherapy is more widely used in other countries in the US, but let's focus right now on kind of what your question is, which is basically what is immunotherapy and, kind of how does it work? So traditional immunotherapy, allergy shots, which is subcutaneous immunotherapy. First, you kind of have to know what allergies are, I guess, right? So seasonal allergies are really, traditionally you get exposure. That's why we don't see seasonal allergies in small children. It's super rare under the age of 3 because you need a few seasons of exposure to the allergens. So if you were born, you might need 2 or 3 seasons or 2 or 3 years of exposure before you start to develop actual allergies. And so it gets more prominent the older that you get, peaking kind of in adolescence and then going down. And so what happens is if you're allergic to something like grasses or pollen, you inhale these grasses or pollen and allergens into your nose. They go down into your respiratory tract, and part of your immune system called IgE creates a reaction where you have mast cells that then create the symptoms. So when you're thinking about and when I talk about IgE, we can talk about it a little bit more later. IgE is really the serum blood test. Have you ever heard of the blood test for allergies? They're measuring IgE. And immunotherapy, the way it works is, so instead of presenting the allergen through your nose and then through your respiratory tract, they take the allergen and they inject it under your skin. And there are immune cells in your skin called antigen presenting cells. And they take that antigen and then they go and present it to other parts of your immune system, like something called T regulatory cells. And what actually happens is these regulatory cells reduce the amount of IgE. They downregulate it. And so you have less of a response the next time you see that allergen. So that's kind of how it works. It teaches your immune system to not recognize the allergen as much, and thereby reducing your symptoms.
Dr. Rolnick, you were explaining about allergy pills I've never heard of. Can you explain a little bit more about that?
Yeah, so sublingual immunotherapy is more widely used in other countries, and the ones that are available in the US that are FDA approved are really limited to ragweed, grasses, and dust mites. So it's not a great therapy for everyone. And the reason is, let's say you have seasonal allergies, but you're to ragweed. But you also have allergies to pet dander. If you do sublingual immunotherapy, which is, we can talk about how that kind of works alone, but you don't address the pet dander, you're still going to have allergies, because every time you're around pet dander, you're still going to have symptoms. Or let's say, even more common, you are allergic to ragweed, but another type of pollen that we don't have sublingual therapy for. Okay, well, every time you step outside, you might have the allergy reaction to ragweed, but you're still going to have it to your other allergen. So it's really only efficacious for people who only have allergies to the specific sublingual therapies that are available. The nice part of it is it's a pill. You put it under your tongue, it rapidly dissolves. You can do it at home. And it has the benefit of not, needing shots. Their shots, I should say, are slightly more efficacious, meaning they work a little bit better. So it really is patient specific, but that's basically the context in which it works, and who might be able to actually use that kind of therapy.
Dr. Rolnick, how would you know what allergies you're allergic to?
So that's a great question. I think most patients think about, when they're thinking about getting a diagnosis for allergies, they really think about like blood tests and the skin prick testing. But actually, that kind of goes back to, what do those tests show us? So skin prick testing and blood testing show us IgE levels for blood testing. And so they show us that you've been sensitized. And that really just means that your immune system has seen this and to what extent they've reacted to it. So it is helpful in that the higher your amount of IgG, for lack of terms, the more likely you are to be allergic, but that really has to be taken into the context of a history. So I might have an IgE level that is very, very high for food allergy, like let's say dairy, but I eat dairy all the time, and when I ask my doctor, do I have any symptoms, and they'll ask me all the different types of symptoms you could have for food allergy like dairy, and I say no. Even if my blood test is really, really high, the fact that on history I'm tolerating that specific allergen and not having symptoms is more important. So it's a combination of the two. You would probably get skin testing is a little bit preferred over serum testing, and then that has to be taken in context with really good and detailed history, looking at what the symptoms are in response to whatever came up positive on your testing.
Dr. Rolnick, you explained about the allergy pill and how it works. Can you explain what the allergy shots work for?
So allergy shots really work best for insect bites. They work great for, so things like if you are anaphylactically allergic to bees, pollens, pet dander, dust mites. Those are the main ones. So they don't work well for things like food allergies, for example.
Dr. Rolnick, since you spoke about pet dander allergies, can you explain or have information about hypoallergenic dogs?
So that is a great question. There's no real research to show that there is the existence of anything like a hypoallergenic dog. Most people who are allergic to pet dander, it's not actually the fur. So hypoallergenic dogs are usually breeds that don't shed as much fur, but what you're actually allergic to is not the fur. It tends to be things like saliva and urine. So the type of fur doesn't matter so much to your allergy. So even patients who have hypoallergenic dogs, if they are allergic to pet dander, are likely to still have some sensitivity to a hypoallergenic dog.
Are there any risks to allergy shots?
Certainly, with all therapies, I think you have to have a discussion about what are the risks versus what are the benefits. And so some of the risks with allergy shots are allergies. Of course, you're introducing an allergy to somebody who's allergic. And the other real risk is for a potentially life-threatening allergic reaction like anaphylaxis. And really the patients who were shown to have the greatest risk for this side effect are patients with uncontrolled asthma. Which can kind of be like a chicken and the egg thing, because sometimes patients with uncontrolled asthma are the ones who really want to get their allergies under control, like their seasonal allergy triggers, to help control their asthma, but they actually can't get the allergy shots until their asthma is controlled. So it kind of can create a little bit of a poor cycle, but those patients are at the highest risk for life-threatening anaphylaxis to their allergy shots. So really most allergen, it's a relative contraindication. It doesn't mean you absolutely cannot do it, but a lot of doctors will be more careful and maybe not suggest this therapy in those patients. And then the other thing you kind of want to consider as well are patients who are on beta blockers, because one of the treatments for anaphylaxis, or the mainstay of treatment for anaphylaxis, is really epinephrine or EpiPens, which works by being a beta agonist, meaning, so blockers are things that block receptors, agonists are things that trigger receptors. So the mainstay of treatment is doing the opposite of a beta blocker. And so patients on beta blockers might be also a relative contraindication to this therapy.
Dr. Rolnick, when you refer our patients to the allergist, what are they expected?
Yeah, I think that's also important, right? Because giving the referral is one thing, but I think it also helps to kind of give the families reasonable expectations for what this therapy looks like. So the first thing they can expect is testing. I usually will have a conversation with the allergist immunologist. Do they prefer that I order the testing ahead of time so they have the results for the first encounter with the patient, or do they prefer doing it themselves? So once we identify what your allergens are, the allergist immunologist will actually, every shot is very specific and made for that patient. So they have a bunch of different commercially made allergy shots, and then they mix it together specifically for your allergens. So the number of shots depends a little bit on, like, sometimes 2 different types of allergies can't go in the same vial, so you might need 2 shots. Or sometimes you have 15 allergens and the volume is too much, and so you need 2 or 3 shots. Or sometimes you have 1 shot or, 1 allergy or 2 or 3 allergies, and they all can be mixed together, and you're super lucky and you get 1 shot. So the number of shots depends on your allergies and what can go together in a vial. You can expect that they're going to use a very small, tiny needle, which most children will be afraid of the first couple appointments, but I'd say after that, most kids realize that the needle is so small that they kind of get used to it. You can expect that you will need to stay in the doctor's office for a little bit of time after your allergy shot to monitor for signs of an allergic reaction. And you really want to be there if that happens, because you want a physician to be available to give epinephrine, watch your child's breathing, make sure their allergy is under control. So you're going to have to stay for a little bit after the shot. And then the last thing is duration of therapy, which I think is probably the most important thing to talk to parents and families about. So allergy shots usually are given weekly until a patient reaches something called maintenance therapy. So that might mean that they need an allergy shot on average. Most patients will need it about 30 sessions. So 30 weeks of once a week therapy to reach maintenance. And then they go to monthly. And you might need monthly maintenance therapy from anywhere to 2 to 5 years. So this is a really long-term therapy. Parents and families need to be committed to being available to do this therapy and see it through the end. If you miss a few, sometimes the allergist immunologist can kind of make up that time miss. Like if you're sick, you might not be eligible to get your allergy shot because of that risk we were talking about earlier. Or if you have asthma and you just had an asthma exacerbation, they're probably going to skip that week's therapy or that month's therapy. So they can sometimes make up for that. But if you miss several shots in a row, you have to start over from the beginning. And so you kind of have to plan and commit to that ahead of time.
Dr. Rolnick, how well do the allergy shots work?
So that's also, I think, a really good question, right? Because it's not 100%. It's about 80 to 85% of patients, which is still really good. And also the interesting thing is that it reduces de novo allergens. So de novo means like new allergies. So potentially allergy shots can reduce your risk of developing a new seasonal pollen allergy, which is kind of cool.
Dr. Rolnick, are there any alternative therapies for allergies?
So I get a lot of patients who ask this question, are there kind of alternative therapies or more potential natural therapies for seasonal allergies? And although I have to say it's not my first line recommendation because there was only one study and it was very small. It was done outside of the United States in patients who were greater than 18 years old, so not really my patient population. There was one study done in Belgium, included around 50 patients who had seasonal allergic rhinitis for more than 1 season and had a positive skin test for seasonal allergies. And they looked at something called Pure Essence respiratory nasal spray, which basically was ocean seawater, rosemary floral spray, and then 4 EOs, which are essential oils. And the other potential weakness we can describe in the study was that some of these patients were already on allergy medicines. So basically they added this medication to patients who had seasonal allergic rhinitis. If they were already taking allergy medications, they stayed on their allergy medications. And the treatment was 2 sprays in each nostril twice a day for 4 weeks. And then they measured their symptoms after 4 weeks. And they found that patients who were on this therapy did have an improvement in symptoms subjectively, but they didn't look beyond 4 weeks. So when I talk to parents and patients about this therapy, I say, was really studied in adults, so greater than 18. The fact that they only looked up to 4 weeks means it's kind of hard to speak to what are the potential side effects of this medication beyond 4 weeks. So we don't really know if you use it for more than 4 weeks, what potential side effects you could experience. And that they were already on some allergy medications, some of these patients, so they didn't really control for baseline allergy medications. So those are kind of the weaknesses of the study and the potential benefits. So it's something I think to be aware of, but also to realize that this study definitely had its limitations. That kind of concludes today's episode on, really we focused, I would say, on seasonal allergic rhinitis. We hope the information is helpful to all the parents out there with children who are experiencing particularly bad allergies this pollen season. And I would encourage you all to talk to your pediatricians about what therapeutic options are out there for you if your child is suffering from seasonal allergies this time of year.
Thank you for watching The Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.